Welcome. I'm Dr. Daniel Rusu, anesthesiologist, intensivist, and neurocritical care physician. Every week in the ICU, I sit with families facing a cancer diagnosis, and almost always the same conversation happens. Doctor, is this treatment going to help? How much time are we talking? Those are the most important questions in medicine. And the honest answer, the one you rarely hear from a press release, from a pharma commercial, or even sometimes from a well-meaning oncologist, is more complicated than most people realize. Today, I want to walk you through what the actual clinical trial data says, not the headlines, not the hazard ratios, the real numbers, how many months, how many years, and for whom. This is educational content based entirely on published, peer-reviewed research. It is not individual medical advice, but it is information every patient and every physician deserves to understand. Let's begin. The headline number. Let me give you the single most important number in this entire presentation: 2.8 months. That is the median improvement in overall survival, meaning how long patients actually lived, across all new cancer drugs approved by the FDA between 2003 and 2021. 234 randomized controlled trials, the best evidence we have, 2.8 months. Now, let me add two more numbers that put this in context. Only 32% of FDA oncology approvals, less than 1 in 3, have ever been shown to help patients live longer. And 68%, more than 2 in 3, have been approved without ever proving that patients survive longer on the drug. And the cost. The median price of a new cancer drug today is around $25,000 per month. I want to be absolutely clear. I am not saying these drugs are useless. Some of them are transformative, but the average new cancer drug, the one getting the press release, the one your insurance company is arguing about, adds about 2.5 months to median survival. That is the baseline you need to know. Metastatic drugs, survival gained. So let's look at specific drugs, and let's be honest about what the numbers actually show. At the top of the chart, we have pertuzumab, combined with trastuzumab and chemotherapy for HER2-positive metastatic breast cancer. The Cleopatra trial showed a median survival gain of nearly 16 months. That is genuinely remarkable for metastatic disease, and it represents the best result ever recorded in a metastatic breast cancer trial. Pembrolizumab plus chemotherapy for first-line metastatic lung cancer, 11 months of median survival gained. Osimertinib combined with chemotherapy, another 10 months. These are real wins, meaningful wins. But as you move down the chart, the numbers get smaller. Bevacizumab for metastatic colorectal cancer, 4 to 5 months. Nivolumab for second-line lung cancer across all patients, 3 months at median. And then there's palbociclib, Ibrance, one of the best-selling cancer drugs in the world, used for hundreds of thousands of women with metastatic breast cancer. In its large confirmatory survival trial of over 600 women, it showed 0 improvement in overall survival. None. In the first-line setting, 0 months gained. This does not mean every patient gets the median, and I'll explain why the median is actually misleading in a moment, but these are the numbers you deserve to know. The FDA approval problem. Here is something that surprises most people, including many physicians. Look at this pie chart. 22% of FDA oncology drug approvals were based on overall survival data at the time of approval. 10% were later tested and confirmed to extend survival. That's 32% total with proven survival benefit. The other 68%? No proven survival benefit. Yet. How is this possible? How does a cancer drug get approved without proving it helps people live longer? The answer is surrogate endpoints. Rather than waiting years for overall survival data, the FDA has increasingly accepted proxy measures. The cancer shrank. That's called a response rate. The cancer didn't grow for longer. That's called progression-free survival, or PFS. These sound like survival benefits, and they correlate with how patients feel in the short term. But multiple meta-analyses have shown that PFS and response rates correlate poorly with how long patients actually live. The thinking was, approve early, get drugs to patients faster, then confirm the survival benefit later. The problem is that later sometimes never comes. Some drugs are withdrawn, many never complete their confirmatory trials, and in the meantime, patients have been taking expensive drugs with real side effects on the assumption of benefit that was never proven. This is not fraud. This is the system working as designed, but it means patients need to ask, was this drug approved on survival data or on a surrogate? Where oncology genuinely transformed outcomes. Now, and this is important, the exceptions are real. I don't want you to leave this video thinking oncology has failed, because for certain cancers in certain patients, modern drugs have done something that would have seemed impossible 20 years ago. Start with imatinib, Gleevec, for chronic myeloid leukemia, or CML. Before imatinib, the median survival for CML was roughly 5 years. Today, patients who achieve a deep molecular response have a life expectancy that is essentially normal. We are talking about 15, 20, potentially 30 years of life gained. For a disease that was a death sentence within a decade, that is the most dramatic transformation in the history of oncology, and it happened because imatinib was a perfect match for the biology driving that cancer, pembrolizumab, in advanced melanoma. About 20% of patients achieved durable long-term remission. Some of them appear to be functionally cured. Metastatic melanoma, before immunotherapy, had a median survival measured in months. Some of these patients are now alive at 10 years. Pertuzumab plus trastuzumab in HER2-positive metastatic breast cancer. 16 months of median survival, as we discussed. The largest survival gain ever recorded in a metastatic breast cancer trial. And osimertinib in EGFR-mutated lung cancer, a targeted therapy that, in the right patient, has turned what was once a rapidly fatal disease into something managed like a chronic condition. The pattern is clear. When you match the right drug to the right biological target in the right patient, the results can be extraordinary. The tragedy is that most metastatic cancers don't have that clean target yet. Early-stage drugs, a different story. Now I want to shift gears because early-stage cancer treatment works on completely different logic, and it's actually where modern oncology has its most defensible wins. When we give adjuvant therapy after surgery for early-stage cancer, we're not trying to shrink a tumor that's already spread. We're trying to prevent recurrence in patients who may already be cured by surgery. So we measure things differently. We don't look at median survival because in most of these trials the median is never reached. Most patients in both arms are still alive. Instead, we look at the absolute difference in the percentage of patients alive or disease-free at 5, 7, or 12 years. Osimertinib after surgery for EGFR-mutated early lung cancer, 5-year overall survival of 88% versus 78% in the placebo group, a 10% absolute improvement. That's 1 in 10 patients alive at 5 years who would otherwise have died. Meaningful? Pembrolizumab in early triple-negative breast cancer, 86.6% versus 81.7% alive at 5 years. About 5 in 100 patients saved. Trastuzumab adjuvant in HER2-positive early breast cancer. At 12 years, a 6.5% absolute overall survival gain. 6 or 7 patients per 100 alive at 12 years who otherwise would not have been. These are real gains, smaller than the headlines suggest, but real and sustained. The NNT column, number needed to treat, tells you how many patients must receive treatment for one to benefit. An NNT of 10 for osimertinib means treat 10 patients, 1 extra person survives. That is actually excellent for an adjuvant cancer drug. 4 things the press release won't tell you. Let me now give you 4 things that the pharmaceutical press release, and frankly, often the journal abstract, will never tell you clearly. First, medians hide responders. When a drug shows a 3-month median survival gain, that could mean 3 months for almost everyone, or it could mean 0 months for 70% of patients and 2 years for 10%. The median is one number trying to describe a very wide distribution. With checkpoint inhibitors especially, the long tail of long-term survivors is the real story, not the median. Second, surrogate endpoints are not the same as living longer. We covered this. Tumor shrinkage and PFS are shortcuts. They feel like wins. They are not always wins in terms of survival. Third, side effects consume the gains. Only 14% of breast cancer drug trials showed improvement in quality of life alongside survival. Fatigue, nausea, peripheral neuropathy, immune-related toxicities, these are real. When a drug adds 2 months of median survival but causes 6 months of debilitating side effects, the math is not favorable. Patients deserve to know this before they decide. Fourth, price has 0 correlation with benefit. Studies have directly measured this. There is no statistical association between how much a cancer drug costs and how much survival benefit it delivers. A drug that costs $25,000 a month is not more effective than one that costs $10,000. The price reflects market dynamics, patent monopoly, and what insurers will pay, not clinical value. What does this mean for patients? So, what should you actually do with all of this? Let me be direct about what this does not mean. It does not mean cancer drugs are useless. The exceptions we reviewed are real and life-changing for the patients who respond. It does not mean you should refuse treatment. That decision is complex, personal, and should always involve your oncologist. It does not mean the research is corrupt. The trials are rigorous. And it does not mean every headline is wrong. It means context changes everything. Here is what it does mean. When your oncologist presents a treatment option, ask for the absolute overall survival benefit, not the hazard ratio. Ask what percentage of patients in the trial actually lived longer and by how much. Ask whether the drug was approved on overall survival data or on a surrogate like progression-free survival or response rate. If you have a targetable mutation, EGFR in lung cancer, HER2 in breast cancer, BCR-ABL in CML, the calculus is completely different. Targeted therapy, matched to biology, is where the extraordinary results happen. Know your tumor's molecular profile. And finally, weigh the side effects honestly. Ask your oncologist what the quality of life data shows. Because months of life are not all equal, and you deserve to make decisions with complete information. The goal of this presentation is not cynicism, it is clarity. The data we have is good data. It just needs to be presented honestly, without the superlatives, without the press release language, and without leaving out the denominator. Thank you for watching. I'm Dr. Daniel Rousseau. If this was useful, share it with someone who needs it.